Thank you very much, everyone, for joining in. Like we said, this present webcast is on the full endoscopic lumbar decompression for spinal stenosis. I will describe the technique to you, and I think that I've got a number of tips and tricks that might be useful to you when you want to establish this technique in your practice back home. So this is me, Siepe. This is where I work, the Schoen Clinic in Munich. And this presentation is brought to you in cooperation with Spine, and the intention behind all of this is really to provide valuable educational material to surgeons all over the world. So spinal stenosis, one of the most common pathologies in the lumbar spine in the elderly patient. Very important, we're talking about patients, the younger patients aged starting at 60. Usually we're talking about patients aged 70 plus, 80 plus, some of our patients. So really, in general, we're talking a little bit about an elderly and often also multimorbid patient population. Now, we do know there are multiple different ways how to decompress the spinal canal and also how to fully decompress the neural structures. As you can see here on the left image, there's a full decompression of the neural structures and of the nerve roots. But obviously, a large excess like that is very invasive, not only for elderly patients, also for young patients. The risk of infection or wound healing problems is much higher. Same here on the right side. If we do laminectomies, then often the spine is destabilized. We will have to use additional instrumentation. So these are actually the type of procedures that we would like to avoid in elderly patients, and obviously we don't want to destabilize the spine. So this is now where the endoscopic technique comes in. This is our setup. We make a small 6-7 millimeter incision, and then through the optical systems, everything is projected onto large HD screens, and then we can insert our instruments. We can check for disc herniations, spinal stenosis, and at the end of the day, we can complete our surgery through a small incision like that, and then we only make a single stitch suture at the end of the surgery. So this is really minimally invasive. The tissue trauma is minimal. There are a number of advantages of this technique over other techniques, even over the microsurgical technique, and I will get back to this later. So when we talk about the decompression of spinal stenosis, first of all, we have to choose the right approach. Now, when we talk about endoscopic surgery, there is no such thing as the endoscopic surgery. We have interlaminar approaches, we have transforaminal approaches, we have posterolateral approaches. So in this case, what we need to decompress are these structures. The spinal stenosis is caused by a hypertrophy of the yellow ligament and a hypertrophy of the facet joints. Over time, they start to compress the neural structures. So this is what we need to remove in order to get a full decompression of the nerves. So in this case, if you choose the transforaminal approach, we will not be able to sufficiently remove these structures. You would have to remove the entire facet joint, and then even then you wouldn't be able to get to the contralateral recess. Same thing applies for the posterolateral approach. We will not be able to fully and sufficiently remove these structures. So now, if we do want to achieve a full decompression of the spinal canal, then really what we need to do is we need to use and apply the interlaminar approach, as we can see here on this slide. So over the coming slides, I will give you some tips and tricks, and some of these tips and tricks are technical by nature. Which scope do I use, how to insert my instruments, how to manually handle the endoscope. But then also, if you want to establish this technique in your unit, there are also a number of strategic considerations. And I will get back to that in the second half of my presentation. So first of all, which scope do you use? Which scopes are out there? You can see there are a number of different scopes out there. The smallest one has a working channel of only 3 millimeters, so that's very, very small. This is the type of scope that we would use for posterior cervical surgery, so posterior cervical foraminotomy, for example. Very small working channel, everything is extremely delicate. Then, as you can see here in the middle, These are the scopes that are used for the lumbar surgeries, lumbar interlaminar or lumbar transfemoral. They have a working channel of 4 millimeters. And then on the right side, this is the scope that we would use for lumbar decompression, 5.5 millimeter working channel. So at the end of the day, we're only talking about an extra 1 millimeter or 1.5 millimeter, but considering how small these type of surgeries are, this is really a huge difference. So the extra 1.5 millimeters really gives you the opportunity to insert bigger instruments, bigger scissors, wider burrs, and that's really extremely helpful when you're doing these kinds of surgeries. The next important thing is when you start with this technique, endoscopically, manually, this technique is quite challenging. Everybody knows that there is a considerable learning curve when you're starting with the endoscopic technique. So overall, I would say start with lumbar decompressions only later on in your learning curve. Start with easy discectomies, then only later on you start with the decompressions. When you do start with the decompressions, these would be ideal cases to start with. So not very much hypertrophied bony structures, but rather start with a ligamentous hypertrophy, so hypertrophy of the yellow ligament here. These are usually a little bit easier to resect. So these would be perfect candidates to start with. The next step or first step of the surgery, our patients are positioned in a prone position, and we slightly open up the operating table. And what that does is it slightly opens up our interlaminar window. So you can see here before and after opening of the operating table, and you can see our interlaminar window here at L5S1 or at L45, and you can see that it really opens up. And now this is our access. So if we can increase our access area, this will make the surgery a little bit easier. And that's why we recommend to slightly open up the operating table once the patient is positioned in a prone position. The next step then is we need to make our skin incision, and that's part of the preoperative planning. Let's say you have a mediolateral disc herniation at the level L5S1. This is where we would make our skin incision, and this really helps you to get underneath the facet joint. In the vast majority of cases, you don't even have to touch the bone here at the level L5S1. Let's say we have a cranial sequester. We would make our incision a little bit further caudally. That helps you in the beginning to get underneath the lamina here. Later on, when you have a little bit more experience using the burr, then this is not a problem, but in the beginning, it will help you to get a little bit better underneath the cranial lamina. And the other way around, you have a caudal sequester, you would make your incision a little bit further cranially. So now what we are talking about is we are talking about an over-the-top decompression. So in that case, we would make our incision a little bit further paramedian, which will help you then later on to get underneath the spinous process to the contralateral side. So this is now another schematic illustration here of what we're talking about. Let's say you make your incision in the midline. You might get stuck later on at the spinous process, might make it a little bit more difficult to get to the contralateral side, particularly when you have stronger and more obese patients. So that's why we make our incision a little bit further off the midline, more to the paramedian, and this will then help you to get better into the contralateral recess. So that's your skin incision. And then let's look at the manual handling of an endoscope. When you are a right-handed person, you're actually doing much more with your left hand. This video is made just for educational purposes. You zoom in, you zoom out, you rotate, you look cranially, caudally. So especially in the beginning, you might be a little bit overwhelmed doing all these maneuvers, and then the anatomy looks a little bit different. And then again, you work through 25-degree angled optics. So that there are a lot of issues that you're dealing with in the beginning. And that's why this small little tool might be a little bit helpful for you. It keeps a fixed distance between the scope and the sleeve. So if you insert this in the beginning, let's say for the first 20, 30 cases, might make life a little bit easier for you. In the long run, however, I would recommend to use the endoscope freehand, like I'm doing in this video here, simply because you're a little bit more flexible and it will be a little bit easier for you to move around. So this is a tool from my point of view, and when you're doing the first cases for beginners. So then, next step, the majority of cases are not located of spinal stenosis are not located at the level L5S1, where we have a very nice wide interlaminar window. The vast majority of cases are located at L4-5 or at L3-4, and you can see that the interlaminar window is much smaller here than at the level L5S1. So usually these cases for beginners are significantly more difficult, and we will have to open up the interlaminar window. We will have to remove some bone in order to be able to access the spinal canal with our instruments. So we will have to use the burr, and we will have to use Kerenson punches. So the first step to do that is you insert your scope, you make a small incision, you insert your scope, and this is the facet joint here. This is always lateral, where we are standing. This is medial. This is our interlaminar window, and we're starting the procedure by removing soft tissue from the facet joint. So we're removing the facet joint capsule, because then in the next step, we can insert our burrs and start removing more of the bony material. So this is what I displayed here. You insert the burr. This again here laterally is our facet joint, and now slowly but carefully, these are very delicate movements. You can see kind of like rotating movements, very easy. You never need to use any force, but you can then slowly but gradually open up your interlaminar window by removing a little bit of this bony substance here, just as much as is required in order to get a full recess decompression later on. So you can see here how we do this. What's very important, the sleeve stays outside, only the burr goes into the interlaminar window. Otherwise, you will kind of be stuck with your sleeve, with your scope. So that's kind of like the tips and tricks, the tricks that you have to learn when you start using the burr. So then there's another educational video here. So you can see the sleeve stays outside on the facet joint. And here we are going inside the interlaminar window, and then we can easily, with no force, maneuver up and down, cranially and caudally, and we can start to remove as much of the bony material as is required in order to get sufficient access to the spinal canal. The next important step is then that we will have to remove more bony material here as part of our recess decompression. You can see that here. And now, only once you have removed more of the bone in the lateral recess with a burr, then we will be able to get in with these Kerenson punches. And we can start to resect more of the bone. I usually still at this stage leave the yellow ligament intact, so we can start to move. We can start and begin this procedure with a bony decompression, and the yellow ligament is still intact and is therefore a protective shield towards your neural structures. The next important step is removal of the yellow ligament. I would recommend that you start to open and go through the yellow ligament more medially, and from there on, layer by layer, we will remove the yellow ligament going laterally. So it's not advisable to simply go in one direction and dig one single hole here, because that will create a flap caudally and cranially. So what you do is you go into your spinal canal. You open the spinal canal right here by removing the yellow ligament, and then you go in a lateral direction, as I will show to you in the next video. So the sleeve is kind of resting on the yellow ligament. That gives you some pre-tensioning, makes it easier to take some sufficient bites from the yellow ligament. And now you can see that we open up the spinal canal here. This is our access to the spinal canal. We can now see the epidural fat tissue. The neural structures will be coming behind here. There's now epidural fat. And from now on, we start going laterally, and we start to remove yellow ligament step by step. So once we have removed these layers here, we will be able to see the dura and we will be able to see the exiting nerve root. I'll show you another video, as this is a very important step of the surgery. If you take your bites, you can see laterally, immediately here, how we open up the spinal canal. And now this is very thick, very hypertrophic yellow ligament. We start to resect this step by step, layer by layer. Just like I mentioned previously, don't dig a hole simply into one direction. Go in layer by layer, and once you have created a certain opening of the yellow ligament, then we can also go in with bigger instruments, such as this one, and start to resect and first of all decompress the central spinal canal. Another option is that we detach the yellow ligament just like we would do microsurgically from its cranial insertion from underneath the lamina. So this is here the cranial insertion of the yellow ligament, and this is where we would start to resect the yellow ligament. Same thing, step by step. You can now see here epidural fat coming. Once we've created a hole, we take the small keratome punch. Once we've created a little bit of a bigger hole in the yellow ligament, then we can go in with larger instruments. Now you can slowly but surely see the neural structures coming. Again, this is medially, this is laterally. Yeah, this is the dural sac now. Our nerve root will be coming down here. And this is how you do it. The step of the procedure is actually very safe, very easy, and can be done quite quickly too. So we have resected our yellow ligament. We have decompressed our central spinal canal. The next step is that we fully decompress the ipsilateral recess on our side. So ipsilateral recess decompression. You can see the neural structures again. You can see the dural sac. Caudally here, you will see the exiting nerve root, as you can see here on this video. Yeah, and then you need to make sure that all of these structures, particularly this caudal corner here, is fully decompressed. So we've done our central decompression, we've done our ipsilateral recess decompression, and the next step is that we are now going over the top to the contralateral side. That's the next step of the surgery. I will display how this is done in the next video. So we're now turning the endoscope and we're going underneath the spinous process to the contralateral recess. So this is my second most favorite instrument that you can see here. There's a lot of hypertrophied yellow ligament. You can see in this way here, we are going into the contralateral recess. We also want to see caudally the contralaterally exiting nerve root, and we want to see all neural structures decompressed sufficiently. Now this is my most favorite instrument that you can see here. It's quite a large instrument, so it makes it easy to remove a lot of these materials, and you can take sufficient bites and remove all of these structures which are compressing the nerve root here and the dural sac. Same thing as in microsurgery. You have to be very careful to not press with your instruments onto the spinal nerve that is exiting here on the contralateral side. So be aware and be careful that you're not exerting too much of force, too much of pressure on those nerve roots. So we might need to use the burr also in order to remove more of the bony structures, bony recess decompression on the contralateral side. It's very important that you see the tip of those instruments so that we don't cause any laceration to the dural sac here. You can achieve that easily by rotating the scope, and with a 25-degree optics, then we can see that everything is fine and that we are not in contact with a burr with the neural structures. And then again, this also is a very, very safe and not difficult part of the surgery. Then again, final inspection, we want to be 100% sure that we have achieved a full decompression of the neural structures, central spinal canal, contralateral recess, ipsilateral recess. We want to make sure that we have fully decompressed the exiting nerve roots, and then you finish the surgery by making a single stitch incision, a single stitch suture, and then you can see here that we can finish the surgery through only a small skin incision, independent of whether the patient is 50 kilos or 150 kilos. And that's really one of the advantages of this technique. Again, final inspection and skin closure. This is just another case, just for demonstration purposes. You can see the central spinal canal is fully decompressed. You can nicely see the caudally exiting nerve root on the ipsilateral side. Later on, I will give you a brief overview of the contralateral side. So you can see here we're going looking contralaterally here. All the tissues that have previously caused compression of the neural structures have fully been removed, exiting nerve root here. And so now we know there's no major bleeding, full decompression, and then we can finish our surgery. And we know that everything has been done nicely. So the technical results, I will show you some post-operative MRI images. This is a patient where we did pre and post-operative images, post-operative MRI 48 hours after the surgery. And you can see here the axial slices after the surgery. All the neural structures in comparison to pre-operatively have been fully decompressed. We can see we can see all the nerve roots here. We can see that not too much of the tissues have been removed from the facet joint. So we have maintained stability, and that's exactly what we wanted. Post-operatively, the patients are fully mobilized immediately. We wait for 2 to 3 to maybe 4 hours until the general anesthesia has worn off. So we're doing all of these procedures under general anesthesia. We think this is much more comfortable for the patient. If you do an easy case of a discectomy, you might be able to do this under local anesthetic, or I know some colleagues do this under regional anesthetic. My personal preference is that the patient is under general anesthesia. I think it makes it more comfortable for the patient and for the surgeon. And by the way, we do not give any muscle relaxants. So if you do get close to the nerve roots, you would still get the muscle response. Patients are afterwards then mobilized immediately. There is no need for a brace. The patient is discharged 2 days after the surgery, which is not related to any medical reasons. From my personal point of view, you could actually do this same day surgery. The patients could go home first post-operative day, but with our reimbursement system, this is not possible. So patients would have to stay 48 hours after the surgery, and then they can go home. This is also very interesting. It goes into the direction of spinal canal stenosis, but the entity is a little bit different. It's that of lumbar synovial cysts. And obviously, you can also do this fully sufficiently with a full endoscopic technique. I will show this to you in the next video. So this is a synovial cyst compressing the L5 nerve root on the left side. As you can see here, all of this here is on the ipsilateral side. This is cystic material which needs to be removed. We kind of face the same challenges as we do when we work microscopically. There may be adhesions, so you have to be very, very careful not to pull on any of these adhesions, because this puts you at risk of causing a dural lesion. So we always have to go in with a dissector or with a bipolar. We have to find the right layers, and once we have identified these right layers, like we do here, I'm going in with a dissector here. Once we have identified these layers, then again we can go in with our Kerazon punches and take sufficient and safe bites. We do this in a craniocaudal direction. You can see right here, there's a lot of cystic material still. All of that was lumbar synovial facet joint cyst. And we do this and we follow this until, again, we can see that the caudally exiting nerve root has been fully decompressed sufficiently. So same thing, it's fully manageable using the full endoscopic technique. Again, we did a post-operative MRI here 24 hours after the surgery, and then you can see that our cyst has been removed sufficiently. Actually, we also have axial slice MRIs, and those images also show that we did not remove too much of the facet joint and achieved a full decompression of the neural structures here. From my point of view, to summarize, there are a number of advantages of working in the full endoscopic technique. One of them is if you have strong patients or obese or morbidly obese patients, it really doesn't make a difference to me. If the patient is 50 kilos or 150 kilos, you still make your same 7-8 millimeter incision and you can fully decompress the neurostructures. Like you can see here, you can do discectomies, you can do decompressions, you can do synovial facet joint cyst resections, you can do multi-level cases. This is a case of a 2-level over-the-top decompression for spinal stenosis. An obese patient, 140 kilograms with a body mass index of 48. So we know that these cases sometimes are very challenging if you decompress them openly or if you decompress them with a microsurgical technique. They are running at a considerable risk of developing wound healing problems afterwards, also because usually of comorbidities such as diabetes. And the risk of wound healing problems is going down to almost 0%. I'll get back to that just now. Yeah, you can do 2-level decompressions, you can do 3-level decompressions, so all extremely minimally invasive. And now we're getting to this topic of infection and wound healing problems. We know that if you want to make small incisions, and when you work with a microscope, and then the surgeon becomes very enthusiastic, you want to make a particularly nice and small incision, then you know that simply technically you're getting to a limit where you cannot make your incision any smaller. So what happens is you make a very small incision, but then you put in your retractor systems and you're starting to put a lot of pressure on the skin, which already makes it a little bit prone to developing, or let's say it increases the risk that the patients might develop infections or wound healing problems later on, because the skin has already been compromised during the procedure. So this is one issue that we do not have when we work with full endoscopic technique. We're making our small little incision, depending on the scope, 6 millimeters, 7 millimeter incisions, and then the scope is inserted and there's never any pressure on the skin. During the surgery, also we use quite a few liters of sterile saline solution. That might also be a factor why the rates and the risk of infection or wound healing problems is really minimal. I would say as close to 0% as you can possibly get. So there's never a 0% risk of infection or wound healing problems, but this is as close to 0% as you can possibly get. So this is all of technical stuff that we have talked about now. Maybe towards the end, I would like to give you some tips, some strategic advice when you are starting with the endoscopic technique. You have previously been working with open techniques or with other techniques or with microscopic surgery even. So there are some strategic issues that you have to consider when you want to establish this technique. There is no doubt about it, and every surgeon knows this. There is a considerable learning curve associated with the endoscopic technique. So from my point of view, I think you really need numbers. This is a lot of this is manual skills, and as surgeons, you need to train these manual skills. I think it'll become very difficult for you if you do one case this week and then only the next good case is only in about 4 or 5 weeks' time. From my personal point of view, I think that this will not give you enough of surgical exposure. So I think you need a certain number of patients, and you need to start with easy cases in order to get enough experience. And that's why I would also recommend, if you start this technique in your institution, it really doesn't make sense if now 4 or 5 colleagues all want to start this technique at the same time, and then everybody ends up doing 1 case a month. Yeah, so it's really important you start with a small team and they do these cases on a regular basis, and this will help you to get to and to train your manual skills in this endoscopic technique. Your team is very important. it's not just the surgeon who has to train the manual skills. Also for your OR team, for your nurses, there is a lot of technical stuff that needs to be known. Your nurses, they need to know how to set up the water pump, the irrigation system, how to connect your video system. So there are a lot of issues, and I would actually recommend that not just you as a surgeon receive training, but also your OR team. That's very important, so that both of you go into your first cases well prepared. Let's say you do start your first cases and you are encountering problems. You are encountering difficulties. Maybe you are losing your anatomic orientation. That's personally where I think when the procedures might become more, let's say, a little bit dangerous. Yeah. So you always need to know exactly where you are. You need to have full orientation. If you think, because you're a beginner, that you are getting lost, my personal recommendation is that you convert the procedure to whatever you have been used to. You might convert to going back to the microscope. You might go back to going and continuing and finishing your surgery in an open fashion. But I really think that patient safety, especially in the first 20 to 30 cases, is very important. If you do have a good technique that you are comfortable with, and now you have severe complications in the first 20 to 30 cases, you burn your fingers, you have complications, then maybe your fancy equipment will get stuck in the cupboard and you will discontinue this technique, which would be a pity, because this technique is really elegant, really fantastic. So that's why for you and for your patients, I would recommend that you start very carefully, very simple surgeries in the beginning, and then from time to time, and with more experience, and with more experience in this technique, then I would recommend that you start step by step to do more difficult cases. So really, this is a mid to long-term investment. The technique is fantastic. You'll get there over time. Start with easy cases. Your goal should not be to now all of a sudden start the endoscopic technique and your primary goal is that you finish the surgery in 15 to 20 minutes. It's completely unrealistic. I can tell you now, that's my experience, that's my recommendation to you. In the beginning, you might need, or you probably need even longer than the technique you've previously been used to and that you've grown up with and that you've trained with. So this is really a mid to long-term investment. Later on, there are some surgeries where you will be much faster with the endoscopic technique, but that only comes later on, and that's not the primary goal when you start working endoscopically. So this is very important. When you do start to learn the endoscopic technique, I would recommend start with very easy discectomy cases at the level L5S1. The reason for that is, as I showed you in one of my previous slides, the interlaminar window is much wider. It gives you much more maneuverability. Only later on, you start with easy discectomies at the level L4-5. This is where you can start practicing using the burr. This is where you can start practicing using the Kereson punches. Then you start with your first lateral recess decompressions at the level L4-5 or L5S1. So again, you get more practice using the burr. Only then you start to do over-the-top decompressions. So this is already what I showed to you manually. This is more advanced. I wouldn't start with this. It will come later on in your learning curve. And then when you think that you're really experienced, then posterior foraminotomies in the cervical spine for far lateral disc herniations are extremely elegant. Then you can, when you do it in a full endoscopic technique, then you can really do these techniques through the smallest, you can do these surgeries through the smallest available endoscopes that I showed you just now with a working channel of only 3 millimeters. So extremely elegant, but you want to be really fit and really experienced with your equipment in order not to have any complications on the cervical spine, and that's why I would recommend this comes last. A lot of information is out there, a lot of advice that you can get. I would recommend, we've done one video on the full endoscopic discectomy and one video of full endoscopic over-the-top decompression, and we've published that in the European Spine Journal. You can go to the OOT website, the Open Operating Theater, and you can download these videos, and it's really like a step-by-step, like a cooking book description almost, on how to do these surgeries. And here you can also read it up. It's also same thing, like a cookbook almost, and then it's a nice description of how you can do these surgeries. Otherwise, there are courses available. You can join courses and you can do fellowships. What I would recommend is that you go somewhere where you find experienced surgeons that are really experienced at the full endoscopic technique. You go there, maybe bring some of your operating staff so that they also get their experience. And then you go back home, you've got everything lined up, and then you start your first cases. Don't wait for 3 months or 6 months. Really start your first cases early after you've done these fellowships. And then I think we have been able to give you a lot of tips and tricks in this presentation. And yeah, I'm wishing you the best of luck to do these surgeries back home. Please don't hesitate to contact us. You can come visit us. You can send us brief emails. And I'm wishing you all the best of luck to do these surgeries at home. The technique is really fantastic. You will need some time to get there and to get the experience, but I'm confident that you can do it. And yeah, your patients will definitely have a benefit using this technique. Thank you very much for joining us. And in case you have any questions, you are welcome to ask them now. We've reserved a little bit of time. So in case you have any questions, then Jochen Breuer-Steinbach will be able to forward them to me now.
Yeah. Thank you very much, Professor Siepe, for this nice presentation. It's always a pleasure. Thank you for sharing your experience. I think they're really, really helpful for all the interested surgeons in the world. As Professor Siepe mentioned, there's a chat function, so if there are any questions right now, please feel free to write into the chat function your questions, and we can immediately see them, and we can talk about them and answer it if possible. So, so far there are no questions. We had participants from all over the world, so thank you for joining this Alliance presentation. This is always a good option to give you information about full endoscopic spine surgery. We have a lot of casts going on nearly every month with different topics. And today it was for sure a highlight because Professor Siepe, he just was in Toronto with us and did some presentations at our booth, and this was also really helpful and really busy, and a lot of interested surgeons are there to discuss things with him. So please use the option now and to discuss with Professor Siepe some topics about full endoscopic spine surgery. There is one question. What size Kerrison were you using in the video, Professor Siepe? Which size the Kerrison are? This is from Stenosis, the Stenosis one, so this is
okay, from a technical point of view, I guess you will probably be able to use to answer this question.
Yes, okay. These are 5 millimeter Kerrison punches for our Stenosis vertebral stenosis endoscope, so they fit through the working channel only of the vertebral stenosis endoscope. The working channel is 5.5 millimeters, and the Kerrisons, they have a diameter of or a size of 5 millimeters.
So I showed you in one of my videos. I showed you my favorite instrument. That is a 5.5 millimeter Kerrison punch. You will only be able to use it later once you have created a sufficiently sized hole into the yellow ligament. So in the beginning, you need to use smaller instruments to get in. You need to start with the scissors, then you need to go in with smaller Kerrison punches. Later on, obviously, this is nice simply because it kind of accelerates the surgery and you can remove a little bit more material. So that instrument then comes at a later stage, but I personally like that instrument very much, and it really helps me.
There's another question: in which direction do you rotate the working channel when you do it over the top decompression?
Well, it's actually you've seen on one of the slides, you don't really have to rotate the scope much. Yeah, you're simply going to the contralateral side, and until you see the neurostructures, you can see the contralateral recess. So you go underneath the spinous process, but there is not much that you need to change with respect to the endoscope. So this is actually an easy part of the surgery. Getting contralaterally is in the over the top technique is actually a really easy step when you do this endoscopically.
So there are so far no other questions.
Okay.
One more question coming. Oh yeah, there's one. How can you handle bleeding in obese patient, mainly cause of high venous pressure?
Okay, that's a good question. It doesn't just apply to obese patients. So as a rule of thumb, the bleedings from epidural veins, they can actually be addressed easily with a bipolar. What you do have to watch though is that you don't use the bipolar too close to the neural structures, and you only apply it shortly. So don't use the bipolar and burn, and then you create too much heat around the neural structures or the nerve roots. So you have to be careful with that. So you only apply it regularly and shortly. So, and that for the majority of cases, it's always very easy to stop the bleedings from the epidural vessels. What you can do for a short time also is that you reduce the outflow of water out of the scope. That slightly, it doesn't increase the pressure inside the spinal canal a lot. That is for a number of technical reasons. I'm not going to elaborate on that. But it slightly increases the pressure in the spinal canal, and the venous bleedings, that's usually only a very low pressure system. So you might stop the outflow, just wait for 1 or 2 minutes, and that will also stop this problem. It's another issue when you have bleedings from the cancellous bone. What you can do is that you use a diamond burr. So in my videos, you've seen that I use a sharp burr simply because it's a little bit faster. I use the sharp burr, but it's preferable if you have cancellous bleedings that you use a diamond burr, and then you can go to those particular spots where there are bleedings, and then you can actually create a little bit of local heat, and that will stop the bleeding. Otherwise, you can also go to those cancellous bleedings with a bipolar, and then you increase the intensity of the current right at that spot. But you just must make sure that you are not too close to the neurostructures, and that you don't apply it for too long, because that will create too much heat. But otherwise, that will also stop your bleedings in over 90% of cases. Otherwise, there are some specialized instruments that are provided to you by RiboSpine, where you can put those instruments straight onto that spot of the bleeding, and that only applies local heat, and then you can also stop these bleedings. So there are a number of tips and tricks, and those will help you to stop bleedings, no matter whether they are from epidural bleedings or whether they come from the